So, introduction. Hello, everyone. Dear colleagues, it's with great pleasure that I introduce this IBSA symposium into this virtual session of the EAU meeting. It's my great pleasure to welcome specialists in recurrent UTI, urinary tract infections. The title of our symposium is Are Recurrent UTI a Problem in Urology, Facts and Fiction? And for this, we invited Dr. Gernot Bonkat, urologist in Basel, Switzerland. He's the chair of the guideline panel in charge of urinary tract infections of the EAU. We will also welcome Professor Galeone, who is statistician in Milan, Italy, as well as Professor Tommaso Cai, very involved in the ESIU and the guideline panel in charge of urinary tract infections. He's a urologist based in Trento, Italy. So feel free to ask questions in the chat. So without delay, I give the floor to Gernot Bonkat, please.
So, Frank, thank you very much for your nice introduction. It's always good to have an interesting meeting. I would like to say, IBSA, thank you as well for organizing everything. Everything went well so far. And I would like to thank you, my colleagues, Carlotta and Tommaso Cai, for joining the symposium as well. I would like immediately to start with my presentation. The title is What do guidelines say for the management of recurrent UTI? And first of all, I have to show or present my conflict of interests. And now we can start. This is a nice view on my hometown, Basel in Switzerland, where I work and live as an urologist. First of all, again, I hope that you, your families, and your loved ones are well during this COVID-19 pandemic and that everything will be a little bit better in the near future. These are my associations or affiliations, and as you can see, I work with the European guidelines as well as with the section ESIU. Just a short word to our guidelines. The European Association has guidelines, and the EIU in general represent the leading authority within Europe, and a lot of over 16,000 members and professionals have joined our ranks, and we have a mission, and the mission is that we would like to raise the level of urological care throughout Europe and behind. And since 2015, it's a big honor for me to be the chairman on the EIU guidelines on urological infection. We have seen very great changes in the last years, and I would like to say thank you again at this time to all my colleagues who are joining the panels, associates, because they are working very, very hard, of course, for free, in their free time, and it's time to thank you at this point to my colleagues and friends. This way you can see that the guidelines are produced by over 300 international members, and our guidelines are endorsed by over 74 national societies and scientific organizations, including all 27 EU member states. This is one of our saying, in God we trust, our others must bring data. In this direction we work, and what you can see on this slide is that the EIU guidelines are very frequently searched in the web, so over 350,000 visits in 6 months. And when you see what are the visitors looking for, then you see they're mainly looking for our guidelines. Here is the new version of the guidelines available. I hope that you can get it, that you read it, and that you have then the possibility to take good care for your patients. This is what we are dealing with. When we speaking about urological infections, then it might be that you say, oh, what a small field, but I can show you it's different. You see, what we have to do is classification of UTI. We are dealing with diagnostics, antimicrobial stewardship, uncomplicated cystitis, recurrent UTIs, pyelonephritis, complicated UTIs, STDs, epididymitis, prostatitis, antimicrobial prophylaxis, so a big field. It was in the past that our sessions were special sessions, not well attended by the urological community, but in the last year, this has dramatically changed, And this is mainly because of one of the three big health topics worldwide, and this is the rise of antimicrobial resistance. And you have most probably all heard already about so-called superbugs. This is what you can achieve nowadays more and more frequently. You take a urine culture and you get such results that you can see that not one antibiotic is working anymore. And this is a really problematic development. This is frequently cited O'Neill report by the O'Neill Commission in 2015. And during this report, it was calculated that in the year 2050, more people will die worldwide because of antimicrobial resistance than by cancer. And this is a shocking number as well. It's already there. There's a problem. Of course, it's not affecting us now in Europe, but if you consider that already in India, about 60,000 newborns aged just from the time of birth up to 1 year, 60,000 young children die every year because of antimicrobial resistance. And then the economic impact, okay, calculated prior to the COVID pandemic, but it's calculated that the cost that you will generate during the antimicrobial resistance problems are comparable to the costs if you compare it with the rise of 2 degrees Celsius above pre-industrial levels in global average surface temperature. And these are not millions, it's trillions. This is what it costs per year the world. Now coming back to the main topic, recurrent UTIs. And I would start with a few shocking numbers about recurrent UTIs or UTIs. So first, UTI, the incidence worldwide is very high, up to 250 million cases per year. Recurrent urinary tract infections are very common about adult women. And more than 2 acute documented infections within 6 months or more than 3 in a year are defining the setting of recurrent urinary tract infection. Then you know that almost every second woman will experience a UTI in her lifetime. 25% of them will then experience recurrence. And it's estimated that 4 to 10% of women suffer from recurrent UTIs worldwide. Why women more often? It's more or less because of the anatomy. The bacteria you can see are mainly coming here from the anal region, and then it's just very near to the entrance of the vagina and the bladder, and then there's an ascending infection into the bladder, and this is why female or women are more frequently affected by UTIs, but of course there are other reasons as well. Small bladder, big consequences. A UTI is not just like you have headaches for a few seconds. Normally, you have then 6 days of symptoms, 2.5 day restriction of activity, 1.2 days on sick leave, work or school, and many women have to go into the bed or have bed rest for a few days. So quality of life, socioeconomic, and antimicrobial resistance are forming this huge problem. Just for clarification, we are speaking about uncomplicated UTI and complicated UTI. You can see that cystitis, pyelonephritis, recurrent UTI, catheter-associated UTI, not to mention, but the first 3 may always be classified as uncomplicated, and if you have risk factors, as complicated. The clinical appearance of a UTI, of course, can differ from a just simple cystitis up to urosepsis. And this is a typical sign of cystitis if you have the frequency, the urgency, the burning sensation. But of course, if you develop a urosepsis, you have still a high mortality. And this is Tanya Roberts, one of the first actors in Charlie's Angels, who died on a urinary tract infection last year on a sepsis. Coming to guidelines, there are different guidelines available how to deal or how to treat urinary tract infection, and especially recurrent urinary tract infection. More or less common ground because the evidence is the same. and the statistics and the techniques how to interpret international guidelines are mainly the same in different societies. So generally, you can decide between the acute phase of a UTI, more or less with the antimicrobial treatment, and then you have many aims for prophylaxis, where we will see in detail in a few seconds. So therapy, we have the therapy of the acute infection. Mainly, you can use antibiotics, of course, painkillers or some alternatives, and prophylaxis we will see later. Now coming to the first question in the setting of an acute infection, what kind of antibiotic you have to choose? And this is what we have written in our 2020 guideline. It's not been changed in the 21 guideline as well. So you see that we have phosphomycin, nitrofurantoin, and in the Scandinavic area, pivmencyllenamine as well. What you can use as well are cephalosporins or trimethoprim or trimethoprim sulfamethoxazole. One drug is missing since a few years. We will come later to that. This is just our panel. Here on the left side, you can see me, Frank, sitting next to Tommaso, is attending the meeting in Florence as well. So it was always a good time. We worked quite hard, but in general, not everyone is following our recommendation. And there are countries where more than 50% of all doctors or GPs are not treating UTIs in accordance with guidelines. It's not that the guidelines are not followed for infectious diseases like cystitis, but for example, this is a nice work done by my colleague Katrin Bausch in Switzerland, which investigated whether appropriate antibiotics were used for the prophylaxis prior transurethral resection of the prostate, and it's not. But it's not that not only the EAU guidelines are not followed. This is a nice article where it was compared the IDSA implementation, the recommendation not to use fluoroquinolones for the treatment of uncomplicated cystitis. And then they investigated how the behavior of the GPs has changed after implementation of the new guidelines. And they've seen no difference with or without guidelines that GPs are not or are still prescribing this kind of drug. We are currently still facing some eminence-based medicine, but this will definitely change in the near future. This is an old saying from gynecologists: doctors are gentlemen and the gentlemen's hands are clear. This was words from the past. Nowadays, you have to consider our guidelines, perhaps as guardrails. It's no law, but this has changed now, because in 2019, there was this implementing binding decision done by the European Commission that the fluoroquinolones are not for the use, or the indication was restricted from the fluoroquinolones to be used, for example, in the setting of urinary tract infection or cystitis. This is the important notice. And now, at least in the EU and as well in Switzerland, if you use fluoroquinolones in the setting of uncomplicated cystitis, as well as prophylaxis in the setting of recurrent cystitis, then you are using them in off-label use. And this is meaning that you have no backup if the patient is developing any severe symptoms or side effects. This was done by the initiation of the FDA a few years later, and they have already warned in 2008 for the side effects of this kind of antibiotics. Now coming to the prophylaxis. And if you are a little bit in the literature, then you know there are many, many means. So we can go for antimicrobial prophylaxis, we have immunoprophylaxis, we have behavioral measures, we have hygiene, estrogenic therapy, demanose, lactobacilli, acupuncture, urine acidification, herbal drugs, phages, vaccinations, and perhaps instillations as a promising approach. I just would like to go through. The antibiotics for the prevention of recurrent urinary tract infection are evidence-based, they work. But the problem is once you have stopped the antibiotics, the UTIs recurred and equate the placebo arm outcome. This is or has been investigated by studies that if you stop them, then you have in many cases the same problem again. If you ask what kind of antibiotics you should use for prophylaxis, then these are the same drugs which are recommended for the treatment of the acute phase. Then estrogens. The use of vaginal estrogens has been shown to reduce UTI rates in postmenopausal women. This is well documented in a Cochrane review, so you can do this as well. Then we have the immunoactive prophylaxis. This is one what we have given a recommendation in our guideline as well. It's a OM89 ingredient. And then we have already mentioned the three things where we see any or some evidence. If I go now to the next slides, myths and facts, then we will see, for example, behavioral measures. For example, if you whip from the front to the back, or you go to pee prior or after you have sexual intercourse. These are many good advices. In some women it will help, but it's not proven by evidence. Fluid intake, it's a good idea. Of course, if you have some symptoms of a UTI, or of course in the same in women who are suffering from overactive bladder, a good fluid intake will help. But again, this is not the magic bullet if you drink fluid appropriate. Then we have the behavior, as I said, to pee pre or post-coital. It's not proven, might be a good advice. Perhaps in some female patients it will help. Then we have the sugar, the demanosis. The idea behind the story, it's quite interesting and fascinating, but as well, there are not many good trials who has investigated these mean. Lactobacilli and probiotica, it's the same, very small studies, no randomization and no long-term follow-up. So it might be an idea, but it's still not to say that this is a magic bullet. As well, the acupuncture route can be tried. Then we have the urine acidification. Again, you can do it, but it's not proven. Now coming to the drugs. Cranberry products as well. There are many studies, at least a Cochrane review as well about the cranberry containing products. But here we have the big problem that the products are not, or the studies are not comparable because of different products, different ingredients, and so on. So again, we have with the cranberry containing products, which is a huge market, huge economic factor, but we are not satisfied with the data to give them a strong recommendation. Phages might be a new idea in the future. Phages are bacterial phages which kill bacteria. They are used in the Eastern European countries and in Russia for years, but so far, again, no studies dealing with this mean. Then we have Chinese herbal medicine. Again, it might be work, might be a good idea. At least you will not harm your patients, I think. But again, no hard data. Vaccination, again, vaccination, a real vaccination against UTI is a promising approach. But again, not many ingredients are tested. And so we have to wait for larger studies. Inhalation, this might be an interesting approach, despite I have to mention that I'm not really satisfied with the current data, but I'm very looking forward what Tommaso Kai today will tell me about this very promising approach. Inhalation, they try to restore the gag layer of the bladder, and at least so far from my personal experience, I can say that in some patients this is working quite well. At least, again, in God we trust, all others must bring data. This is my statement for all the different means, approaches to treat recurrent UTI, bring good data, and then we bring it in our guidelines. And I would like to summarize that the urinary tract infections among women are the most common bacterial infections, that many women are suffering from this disease, that we have antibiotics, estrogens, and immunoactive prophylaxis that can reduce the frequency of recurrence based on evidence. There are a number of other preventive measures. However, these are not, I must say, yet evidence-based, but as I said, I'm looking forward to what I will hear later. And the patients and attending physicians often need patience and time to resolve the problem, because a multimodal therapy concept might lead in many, many cases then to a good end for the patient, that they can get rid of this disease. So, but we should not forget, we should not harm our patients. So we have to see what we can do. And this is my last slide. I would like to thank you. I hope I have been in time, and I'm looking forward now to the next speaker, who will show us interesting data on a review between GPs. Carlotta, the stage is yours. Thank you very much.
So, thank you for this invitation. Thank you for Okay, thank you for the invitation and for the presentation. I'm Carlotta, and the title of my presentation, and this is not the correct slide kit. This is not my slide kit. Thank you very much. And the title of my presentation is Assessing Real-World Prescribing Patterns and Opinions on Antibiotic Resistance. And this is data from a survey, an interesting survey. And we conducted a survey on a convenience sample of European urologists, male European urologists, during several urologist congress meetings in 2018. And we collect data from about 200 international urologists, male European, using a structured questionnaire and validate questionnaire. We aim to describe the management of recurrent urinary tract infection, RUTI, in clinical practice. So this is a snapshot of prescription and opinion. And briefly, the characteristic of survey respondents, the distribution by age, the median age was 46 years old, and it was the distribution is quite similar in strata of age, and distribution by country. Mainly clinicians were European, most of them, more than 70% were European, and a few other from the other countries. And for this reason, no analysis in strata by country was performed. So this is the descriptive summary of the answer of each question of our brief survey. How many patients with an episode of lower urinary tract infection do you see in your clinical practice in 1 month? And most clinicians report to visit between 20 and 50 patients per month for lower urinary tract infection. And this is the distribution. So half are in this setting. In your opinion, out of 100 patients affected by UTI, how many patients present a recurrent urinary tract infection in your clinical practice? And most clinicians report that up to 40% of their patients with UTI may present an RUTI. So this is the most frequent answer. But 37% are from 0 to 20%. And when do you usually start antibiotic therapy for the treatment of a RUTI episode? And about the most frequent answer was as soon as possible without waiting for antibiogram culture results, or always after antibiogram tests. So the two most frequent answers are these two one. And which of the following antibiotic therapies do you usually prescribe for the management of a RUTI episode? For the management is include acute phase and prophylaxis, so it's a quite management of RUTI episode. For a statistician as me, it was quite difficult to understand what was the most frequent answer, because is very complicated, because there are many answers, many combinations, but we found that the answers were largely heterogeneous. A large number of antibiotic therapies were reported, but we see that most frequent are fosfomycin and amoxicillin, and this nitrofurantoin. So this is the most frequent, but it's very, very heterogeneous, the answers. How often have you had to change antibiotic therapy during the treatment of an RUTI episode? And most clinicians report the need to change antibiotic therapy at least sometimes. So there are some problems with the change antibiotic therapy. Sometimes it's the most frequent answer, but only a few, rarely or never. So I have to change antibiotic therapy. And so we ask, do you consider antibiotic resistance a relevant problem in your clinical practice? And we see that the problem of antibiotic resistance is considered irrelevant by most, if not all, clinicians, and with no difference in strata of age. So this is extremely relevant, and quite relevant at the most frequent answer. And in your opinion, what has been the trend of antibiotic resistance in your clinical practice in the last 10 years? And about 17% of clinicians noted a slightly increased trend of antibiotic resistance, and about 20% report a significant increase in trend. Also, this answer, there was no difference in strata of age. Do you prescribe antibiotic for the prophylaxis of RUTI in your clinical practice? And 60% answered to prescribe antibiotic for prophylaxis RUTI. Do you adopt a non-antibiotic method for prophylaxis of RUTI in your clinical practice? Is more frequent, is more than 70% prescribe a non-antibiotic method. And so we ask several questions about, based on your experience, how do you rate the efficacy of this non-antibiotic treatment in RUTI management? This slide is full of numbers, quite difficult to understand, but we see that the most frequently prescribed are prophylaxis with cranberry and prophylaxis with probiotics. And when we ask about efficacy, the most frequently considered extremely effective are the most endovesical instillation of hyaluronic acid with and without chondroitin sulfate, and prophylaxis with probiotics. So this is the most frequent. This is not evidence-based, but was an opinion on experience of this clinician. Then, do you think that you will continue to prescribe, or will start to prescribe non-antibiotic treatment for RUTI management in the future? And more than 70% of clinicians reported that they will likely continue to prescribe non-antibiotic therapy for the management of your RUTI. And other consideration results were similar in strata of age of responders, And several limitations should be considered in the interpretation of these results, mainly because this is a convenient sample and this is not a probabilistic strategy of sampling. So, but it's quite interesting to have a snapshot of clinical practice in the real world setting. And so the conclusion of this presentation, we see that more than 40% of respondents reported that they start antibiotic therapies for treatment of an RUTI episode as soon as possible without waiting for antibiogram and culture results. And changing antibiotic therapy during the treatment of a RUTI episode is frequent. And it's good that antibiotic resistance is considered a relevant problem, extremely relevant for 40%. Finally, 17 prescribed antibiotics for the prophylaxis of UTI, and more than 70 prescribed non-antibiotic methods for the prophylaxis of RUTI, and the most frequent prescribed are cranberry and probiotics. And the most frequent considered extremely effective for prophylaxis are endovesical instillation of hyaluronic acid in combination or not with chondroitin sulfate and probiotics. So finally, more than 70% declare that we will continue to prescribe or will start to prescribe an approach without antibiotics, non-antibiotic treatment for UTI in the future. So this is the end of my presentation. So now we thanks for your attention, and now Professor Kai will start the last presentation of the last section. Thank you.
Many thanks, Carlotta, for this very interesting presentation. I would like to move with my presentation. I would like to say my special thanks to the IPSA company for inviting me to speak about the role of glycosamine glycan therapy as an alternative to antibiotic for the management of and the prevention of recurrent UTI. I have no disclosure statement. I have no disclosures to discuss. This is my agenda for today. Firstly, I would like to discuss with you the management of cystitis in the era of antimicrobial crisis, as Professor Gernot clearly highlighted. Moreover, I would like to discuss with you the importance of the role of antibiotic-sparing approach in uncomplicated UTI, and in particular in the management of recurrent UTI. Finally, I would like to discuss with you the pivotal role of glycosamine glycan therapy for improving our antimicrobial stewardship adherence in everyday clinical practice. And the most important aim for today is convince you that I'm right, of course. So I would like to start with a question for you. The question is why are we still talking about antimicrobial treatment in the management of uncomplicated UTI 80 years after the discovery of penicillin? This is a very important question to do. I think that in the 80s, we were happy under the protection of antibiotics. But now what's happened? Bacterial resistance destroy our protection. Bacterial resistance destroy antibiotics. And the question is, how we can overcome the problem? What we do, a first solution could be find a new umbrella, but as you all know, the number of new antimicrobial drug approval is decreasing in the last year, as the number of new antibiotics in the company pipeline is very low. The second solution could be the change our point of view. I think that this is a very important aspect to highlight. We needed to change our point of view because the medicine changed, the pain chain changed too, and also the bacterial change As you will know, the prevalence of resistance to fluoroquinolone, a broad-spectrum antibiotics in gram-negative uropathogen, is increasing, as clearly Gernot demonstrated. A new approach is urgently required. Our guideline, as reported by Gernot, suggests to inquire about our local bacterial resistance, suggests to perform a correct assessment of all patients related and all bacterial-related risk factors before prescribing antibiotics. Moreover, our guideline suggests to know the exact pharmacological and pharmacokinetics characteristics of antibiotics that we want to use if indicated. But the most important aspect to highlight is that our guidelines suggest to avoid the overuse of antibiotics. Even if our guideline clearly suggests some steps to perform in everyday clinical practice, we have a lot of gray zone to take into account. First of all, antibiotic treatment is able to eradicate the bacteria, of course, but is not able to prevent recurrence. Another important green zone is the fact that antibiotic treatment can lead to long-term impairment of the normal microbiota of the vaginal and bowel tract, and the antibiotic treatment is associated with the development of multi-drug resistant microorganisms. But what is the patient's point of view about the recurrent UTI? In not yet our published study, we demonstrated that the recurrent UTI is associated with a higher level of stress and anxiety in a woman affected by recurrent UTI when compared to sporadic UTI. And the impairment of quality of life in this kind of patient is very high. Moreover, in the same article, in the same paper, we stress the fact that a prompt diagnosis, risk factor identification, and early management is essential in order to reduce the number of symptomatic episodes, to reduce the level of stress and anxiety, and improve patients' quality of life. And moreover, it's very important to highlight that in early management is able to decrease the number of unnecessary antibiotics and improve our adherence to antimicrobial stewardship. But what does it mean, early management? Several years ago, we developed a simple tool to use in everyday clinical practice in order to predict the recurrence risk in women with a symptomatic urinary tract infection. In particular, we focused our attention on the woman with recurrent UTI. According to our nomogram results, we stratified all women enrolled in our study into 3 groups: the low risk of new recurrent episode, symptomatic episode, a moderate risk group, and the high risk group. On the basis of our nomogram results, we suggest to perform an active prophylaxis in all patients in a high-risk group. But what does it mean, active prophylaxis? Several years ago, we stated that a tailored approach according to the patient's risk factor and bacterial characteristic is a promising option also in the prescription of antimicrobial sparing approach to recurrent UTI. I would like to ask you to avoid to prescribe antibiotic in recurrent UTI prophylaxis, because the use of antibiotic as a prophylaxis in recurrent UTI is associated with the antimicrobial resistance, of course, adverse effects, recurrence, and development of multi-drug resistance strains. On the basis of this consideration, it is important to focus our attention on the relationship between bacteria and the host. This is the good strategy to improve our adherence to the guideline, of course, but it is also important to increase the patient's quality of life and improve our adherence to antimicrobial stewardship principle. As you all know, as Gernot clearly stated, that blood epithelium is protected by a glycosaminoglycan, a two protein characterized by the presence of hyaluronic acid and chondroitin sulfate. This is a very important paper published 2 years ago in the PLOS ONE journal. In the case of absence of glycosaminoglycan layer, E. coli is able to attack urothelial cells, destroy the urothelial cells, and here you are, the symptoms. This is a very simple physiopathologic example of the acute UTI. But moving to the core of my presentation, I would like to discuss with you some interesting results about the use of hyaluril, the hyaluronic acid and chondroitin sulfate preparation for the endovesical instillation that has been published from several years ago. First of all, I would like to remember you the first study of Damien Rocco Damiano and co-workers from Italy. They demonstrated that the use of hyaluril drug is able to reduce the rate of urinary tract infection and improve the patient's quality of life. The same results has been obtained also by the study from Vita and co-worker. Moreover, another important aspect to highlight is that the use of hyaluril is associated with the reduce of UTI recurrence, reduce the use of antibiotics. In other words, the use of hyaluril is associated with an improvement of our adherence in antimicrobial stewardship in everyday clinical practice. Moreover, other paper from Chani and co-workers published a few years ago in the medical journal Open demonstrated that the hyaluril drug, hyaluril instillation, is associated with the reduced number of UTI, and in particular, the hyaluril is able to reduce the risk of recurrence. In other words, the hyaluril is able to reduce the patient's anxiety and stress and improve the patient's quality of life. But another important aspect to highlight in order to plan our approach to recurrent UTI is to highlight that the hyaluril therapy is associated with a long-term efficacy, improved quality of life, reduction of Norman on visit, and the most important, reduce of antimicrobial use. This is a very important slide to take in mind. Another demonstration, another endoscopic demonstration of the efficacy of hyaluril instillation has been demonstrated a few years ago by Elisabetta Costantini from Perugia. They demonstrated that hyaluril is able to repair the normal urothelium and create a new barrier against the bacteria, So, moving to the conclusion, I would like to show you how the presence of glycosaminoglycan is able to avoid the attack of E. coli to the urothelial cells, and the therapy with hyaluril, the presence of glycosaminoglycan is able to improve the patient's quality of life. Here we are, the patient is happy. In conclusion, I would like to suggest to you to keep in mind that the glycosaminoglycan therapy, hyaluril therapy, is safe and useful in the management of patients with a recurrent UTI. Glycosaminoglycan therapy is able to improve patients' quality of life. Moreover, the therapy with the glycosaminoglycan is able to decrease the number of repeat UTI episodes and The most important aspect to highlight is that the glycosaminoglycan therapy is able to improve our adherence to antimicrobial stewardship program. Many thanks for your attention.
So, dear friends, it was so good talks, very nice and very interesting. So we have a few questions and we have time for that. And maybe chronologically, we can start with Gernot, if you're okay. Gernot, we've got many questions for you. And the first one maybe is about the adherence to guidelines. You told us that it was difficult to adhere to guidelines all the time. Do you have any advices for that?
Frank, thank you very much. Great question. I would answer with a saying: we change our behavior when the pain of staying becomes greater than the pain of changing. And all in all, I think if you would like to increase
I think we've lost our friend. What do you think, Tommaso?
So, many thanks, Frank.
Suffering from it. And so I think we should follow the guidelines and recommendations.
Sorry, Gernot, we've lost you for maybe 10 seconds, so it was not so clear. But we have so many questions, and also about urine culture in every recurrent UTIs. Do you advise this? Do you use urine culture for each episodes?
I do it because I'm interested whether there's a change regarding the bacteria that cause the infection. And sometimes you have a change that you have, for example, an E. coli, and the next infect you can have a Klebsiella. Then you have different antibiograms, and you have then to choose different options for the treatment. So this is what I do. And at least I would like to know, because sometimes there are overlaps between other diseases. So I'm always interested whether there's really a true infection or, for example, other disease.
Tommaso, maybe you want to comment?
Yeah, I totally agree with Gernot, but I would like to suggest to pay attention to the urine culture in women with the recurrent UTI, because several times the patients are not able to understand the significance of asymptomatic bacteriuria. And if they see a bacteria in the urine, they ask to the doctor, "Oh, doctor, please give me antibiotic." And in recurrent UTI, I suggest urinary culture only in case of symptoms.
Okay, good. Gernot, there is another question for you about estrogen, but estrogen in premenopausal women. What do you think?
Again, good idea, but what I think what we have to consider, you have to make a swab from the urethra. It might be the case that even in a premenopausal woman, there are already some change because of estrogen deficiency. So I would strongly recommend, prior to think about such a treatment, that you take a swab and that you can see this karyoprognostic index, that you can then have a little bit guidance. I personally have never treated a premenopausal woman with estrogens, but perhaps I can return the question and ask you, Frank, have you any prescribed estrogens to a premenopausal woman?
No, I do not do that, but I wait for further studies to do that. But maybe Tommaso has an opinion.
I totally agree with you. I do not use estrogens in premenopausal women. I do not find any clear demonstration to use it.
Maybe, Gernot, we can move to Carlotta's talk. Maybe you have a question for her?
Carlotta, I'm a little bit interested in this question regarding the other antibiotics. And you have already give a great talk about the situation, but what are the other topics? I'm always interested, for example, because of the setting with the fluoroquinolones. Are among the other drugs fluoroquinolones as well? Would be my first question. Are they still prescribed in Europe? And my other question would be, is there at least a chance that some GPs are prescribing combination therapies for the treatment of recurrent UTI or the prevention?
Okay, for the first question, for the fluoroquinolones, we found if you responded that reported to prescribe it, and it was only a few clinicians, and it was the survey was performed in 218. And the combination for the combination of antibiotics was very complicated to understand, because there was a lot of type in combination for antibiotics in the answers, and it was quite difficult. And as stated before, amoxicillin, fosfomycin, nitrofurantoin was the most frequent alone or in combination. And this is from the survey. I don't know in the clinical practice, is it correct according to the guideline? I ask to you. Is in line with the guideline?
To choose fluoroquinolones or combinations, I must say no. So mainly we choose for the prevention the same antibiotics which were recommended for the treatment of an acute episode. But what we have to consider that these are only a few drugs, and in some drugs in the future, because of the resistance problem, the indication to be given as a prophylactic antibiotic might be changed as well. So, but at the moment, it's still possible to prescribe nitrofurantoin, fosfomycin, and other drugs, for example, like the pivmethylamine in Scandinavian countries.
So, Gernot, in Italy, we have two specific scenarios. The first, among the general practitioner, the most common antibiotic used for the treatment of a recurrent or acute UTI is fluoroquinolone, even if not indicated, but they generally use. Another scenario is the gynecologists or among urologists, and they use, first of all, fosfomycin, nitrofurantoin, of course, in line with our guideline, but they use fluoroquinolone in combination with other antibiotics such as cephalosporin or glycosaminoglycan in the relapse and second line. We have two different scenarios in Italy.
Okay. And is it in accordance with your national guidelines, or do you use the European guidelines for that?
No. We use, in Italy, we use the European guideline. Okay. We have performed an adaptation of the European guideline.
Okay. Tommaso, there is a very good question in the chat about the gag layer. Is it possible routinely to see if this gag layer is broken?
Oh, I think that the glycosaminoglycan layer is our most important barrier against the recurrent UTI and against UTI. In my clinical practice, I generally use one instillation of hyaluronic per week in the first month, and then two installation for the second month, and then one installation each week until the patient is not good. I think that the most important aspect to sharing among the urologists and among gynecologists and all physicians that managing urinary tract infection and recurrent UTI is to share the information about the avoid of antibiotic, of course, but then about the importance of the layer, glycosaminoglycan layer defense against antibiotic.
Okay, thank you for your answer, because we have many questions about the schedule you advise about the gag or hyaluril use. So can you repeat it? Is one per week for a month, and after that?
So the first month, one installation per week, 4 installation in 1 month. Then after this schedule, I use 2 installation per month, 1 installation each 2 weeks, and then I suggest to use 1 installation per month until the patient is not good. I think that and I find a good adherence to the patient to this schedule, because regardless the cost of the therapy, the patient are happy, decrease the number of urological visits, and decrease the use of antibiotics. I think that it is the good and the right way to follow.
And do you need a urine culture before installation of hyaluril?
No, no. I don't request any urinary culture before the installation, because I suggest to perform urinary culture only in case of symptoms.
Okay. Some attendees recommend to use gentamicin in injection into the bladder with the hyaluril. Do you use gentamicin routinely? No.
No. Several years ago, we used regularly gentamicin in bladder installation, but now we did not find any sense to use aminoglucoside plus hyaluril for the treatment, for the management of recurrent UTI.
Okay, thank you. Gernot, there is a question for you about diathermy trigonal resection of the bladder for recurrent UTI. Do you use surgery for your patient in case of recurrent UTI?
This kind of surgery, not what I have sometimes done. I know that there's not such a good evidence. The dilatation of the urethra. I've learned it from a colleague who has worked in the United Kingdom for years, and there's approach. If a woman is coming, for example, to recurrent cystitis, that you dilatate in the theater, the operation theater, the urethra. And I have some, but it's not a study, but I have good experience, for example, with dilatation in combination with installation. And this would be a question I just would like to Tommaso, if you allow, Frank. I have 2 questions myself for Tommaso. The first question would be whether this installation therapy, in your opinion, is safe. You have spoken about your schedule. The women are coming a few weeks for installation. Have you observed any problems regarding the installation, that they might develop an infection after installation because of the catheterization? And my other question would be, as we have heard, we have many different means to treat, or to what we can try to avoid recurrent urinary tract infection. Where do you see the installation? Prior, the sugar, the demon nose, after, or a combination? What is your experience? 2 short questions, please.
Thank you, Gernot, for this very interesting question. So rarely I have had urinary tract infection after hyaluril installation. However, in case of urinary tract infection after the installation of hyaluril, I suggest fosfomycin 2-metamol. And the patients, even if had urinary tract infection due to the bladder catheterization, is always continue to the treatment, continue to the bladder installation, and she did not stop the treatment. This is a very important aspect, because hyaluril treatment is associated with a higher compliance to the treatment. Moving to the last question, generally I discuss with the patients about the possibility of the treatment in recurrent UTI. Moreover, the patients are very informative about by using the Google Doctor and the other internet application, and they have a lot of information about recurrent UTI, and they generally ask about blood relation with hyaluronic acid and in association with other compound, dimanose, for example, or cranberry, even if we have any demonstration to the efficacy. However, my suggestion is to discuss with the patients about the blood installation and the association with the other product.
Oh, thank you, Tommaso. Thank you, Gernot. I have to conclude now. Thank you, Carlotta. So in conclusion, our speaker really demonstrated that following guidelines is a key attitude for your routine practice, and gag therapy is recommended for recurrent UTI. The survey demonstrated that user feelings clearly put the hyaluronic acid as a key non-antibiotic treatment for recurrent UTI. And the gag therapy has several significant studies that confirm the guidelines. Especially with Hyaluril. I want to sincerely thank IPSA and our three speakers, Gernot, Carlotta, and Tommaso. I wish you all a good virtual meeting. Bye.